And also you may have a history of infertility. If you have PID or have had PID or have chronic PID, because PID can cause like serious, like permanent damage to your reproductive organs if it's not treated in a timely manner. Also, this is an infection, so there may be elevated white blood cells, which is called what? Leukocytosis. Yes, that's elevated white blood cells. The white blood cells are leukocytes. When there's an increase in them, that condition is called leukocytosis. The patient may be asymptomatic, or the disease may produce only minor symptoms, even though it can seriously damage the reproductive organs. So someone may have PID and have no idea that they have PID, or just have some minor symptoms and never know it. All right, down to the bottom paragraph. Highlight the first two lines. The sonographic findings may be normal early in the course of the disease. So early on in PID, the pelvic structures, the uterus, ovaries, fallopian tube, all that may still look normal. As the disease progresses or becomes more chronic, a variety of findings may occur, and it's from case to case. And it also depends on the severity. Okay. Salpingitis is inflammation of the fallopian tube. It can be acute, subacute, or chronic. Clinical signs may range from asymptomatic to pelvic fullness or discomfort, or a low-grade fever, because it is inflammation. You may have that fever. An obstructed tube filled with serous secretions is hydrosalpinx. So if the fallopian tube is just filled with fluid, then it's hydrosalpinx. The dilated tube may show a pointed beak at the swollen end of the tube near the isthmus where the tube enters the uterus. Do you guys remember the portions of the fallopian tube? Like if this is our fallopian tube, and it's got 4 sections. What's this one? Infundibulum. What's this one? Ampulla. Isthmus. Interstitial. What? That's these. Alright, and then say this is our uterus. What is this area right here where the fallopian tube enters the uterus? Cornua. Yes.
Crown. That's how I remember it. Crown, cornea.
Oh, gotcha. Crown of corn, maybe?
Corona.
We're in Alabama. The corn on the cob, like glued together. The crown.
I think I missed the slide again, by the way.
Which one you missing?
Number 5. Have we got things?
No.
Yeah, we haven't got there yet. It's birthday girl.
Well, no, she's done hers.
You're done?
Her birthday.
Good.
Well, I guess someone hadn't been listening to me. Okay.
I think find out what it is.
So a hydrosalpinx, that is fluid in the fallopian tubes. May have that pointed beak at the swollen swollen end of the tube near the isthmus where the tube enters the uterus. However, this is isthmus interstitium. I don't know why they put that there. If dilated tube becomes infected, it's called pyosalpinx. So when the infection really sets in, pus starts to form, pyosalpinx. So hydrosalpinx is fluid in the fallopian tube. Pyosalpinx is pus in the fallopian tubes. Infected or hemorrhagic pelvic fluid may also be present. Infection can obscure normal tissue planes, making anatomy unclear. So there can be all this extra fluid in the pelvic cavity, which there usually is in severe cases. And it can be infected or hemorrhagic, so you may see internal echoes in this fluid. It may not be, pretty anechoic fluid. You may see some low-level echoes in there. And that's due to infection or hemorrhage.
How they get up, they drain it?
They can. However, I think that was, nope, that's not it. I said we were getting there. But, you can drain it, but with PID, it does respond to, antibiotics pretty well. So the patient, depending on the severity of it, they'll be put on antibiotics. They may have to get really strong antibiotics, and may even have to, have it administered through an IV. And if that doesn't help, then they can have the fluid drained. Okay.
Number 5.
I used to try to stay with the book. I'm totally not. Where are we?
We stopped at
Infected, and then the infected or hemorrhagic comfort. Thank you. All right. Severe. Okay. One symptom that can occur with PID is that the patients can have severe pain. And this, I actually had a patient that was like this one time. I was trying to do the transvaginal on her because you get more detail that way. And so you want to do the transvaginal if you can, but sometimes the patients are hurting so much from having all this infection in their pelvis, they can't really handle the transvaginal very well. So you'll just, kind of get what you can, and then take the probe out, and then look transabdominally. I would look first before I would have them fill their bladder, just in case there is a big collection of fluids. That way you don't get it confused with the bladder. Check that way first and see if you can't get all your images that way. And if they don't have all this fluid, then get them to fill their bladder and check that way. Okay? All right. Sonographically, under sonographic findings, the normal fallopian tube is generally not visualized unless fluid surrounds it. So we don't usually see it unless there's a lot of pelvic fluid out there, and that kind of outlines it. But it should be a thin, less than 5 millimeter, hypoechoic tissue band originating from the uterine fundus at the cornua. If fluid, pus, or products of conception fill the tube, detection is easier. So if there's fluid or some pus or an ectopic pregnancy in there, it's going to dilate that fallopian tube or that oviduct, and we'll be able to see it and locate it better. All right, down to the next paragraph, second sentence. Hydrosalpinx has variable presentations from subtle dilated tubular structures to massive tortuous cystic areas. And this is all due to the amount of fluid. This is due to the amount of fluid that is in the fallopian tube. And then they can be asymmetric in size. It's commonly bilateral, but one fallopian tube can be larger than the other. And they kind of have that shown in figure 43 too. It looks like the left one's larger than the right. Alright, so last sentence of that paragraph. Hydrosalpinx may present as echogenic fluid or fluid debris levels indicating infection. I don't really like how that sentence is worded. It sounds confusing. But so whenever it's anechoic fluid, it's hydrosalpinx just because it's just normal, kind of clear fluid. But once infection sets in, you start getting those internal echoes, and that becomes pyosalpinx. The pus is forming. Okay, so here is hydrosalpinx. And there's another hydrosalpinx. See how kind of curvy it is? Okay. Okay. Severe and chronic. Now this retains pus and overdose with inflammation. That's down in the box, table 43-1. I probably put a little star by that so that you can go back and look at it. And also back on 1029, box 43-1 and 43-2, put a little star by those two because those kind of summarize a lot of the text. So those will be good to go back and look over. Nope. Those are my favorites. These are the only kind that I buy. Are the honey lemons. Yeah. What? Tobacco.
Purse shirt.
Well, you know, when it roll around in the purse, well, it's a
Purse shirt.
They
They've been in
like
it that long. They've been in it that long.
All right. So severe and chronic pyosalpines often contain thick, echogenic mucoid pus. Sounds like what you put on your dress and that's Thanksgiving. Now y'all are eating dressing at Thanksgiving. Y'all think about that.
We saved so you could ruin Thanksgiving.
All right. All right.
Ralph cook your Thanksgiving?
Ralph cook your
Let me see cigar ashes everywhere.
Ralph.
No, he doesn't. Francis cooks.
Billy Ray?
That's my papa's brother. My papa was Essie. That's his name. S.C. Ray. That's his entire name. 5 letters, his entire name. Essie Ray. No.
No, really? No.
They can't.
They just
put letters together.
Oh my goodness.
Here's S.C. L.C.E.C. Okay.
No,
I'm serious.
Well, how did Ralph?
He came from us.
He was one of the first.
Yeah.
No.
He was the only one that had kind of
Seems like you're gonna want to tell us a story there.
There are not enough hours in the day about all these stories I have. All right. So mucoid pus. All right. A pyosalpinx may appear as a complex mass. And then down to the next paragraph. Acute salpingitis is evident as a thick-walled nodular hyperemic tube. So it's going to be inflamed. Kind of, have you guys talked about cholecystitis yet in abdomen in intro? Like the gallbladder wall will get thickened whenever the gallbladder is infected. Well, same thing with the fallopian tube. When the fallopian tube gets infected, the walls will thicken. That's really with any organ. Whenever there's an infection, it's going to thicken. Like with endometriitis, when the endometrium is infected, it will thicken. And then there's that infection I showed you with endometriitis, that increased blood flow. So here you're going to have an hyperemic tube. That's what that means. There's going to be a ton of blood flow on there whenever you put that color Doppler on there. The dilated tubes usually surround the ovaries like 2 lunar crescents, encircling the posterior surface of the uterus and filling the cul-de-sac. That's what figure 43-2 is demonstrating right there. I always thought it looked like some weird monster with like big arms or something, and then like arm hair sticking out for the ovaries or something.
Larry.
You name him Larry the Lobster?
From SpongeBob.
I know, yeah. Larry. Oh, look at Larry right there. He was like, what?
He was like, what?
All right. Okay.
So that's just one. Number 7, that's 7.
Are you asking me to get a ovary cannot be, no, it's not there yet.
So what about the RS?
Okay. Alright, so here's us the pilot cell pink. See how there's all these internal echoes here, whereas we didn't have with hydrocell pink. Here's another one. That one looks all nasty. Look at all that pus.
I can't even tell where the tube is.
It's all this curviness. It'll look like and you see this one kind of looks like an S shape because it expands. Think of it as something that if it's real small, but if it expands, I don't know, kind of think of it as like a little balloon. It can fit right there, but then you start blowing it up. There's only got so much room. It'll start bending, right? If you have a long balloon, the tall ones they'll start bending and cooling because there's no room for it to go. Right? You got it, Jessica?
I got it.
Okay. All right. The sonographer should be sure not to confuse a dilated tube with a dilated ureter or prominent vessel. And how you do that, prevent from confusing that, is if there is a dilated ureter, you can check for hydronephrosis. What's hydronephrosis?
It's fluid in the thing.
Back in the
Kidney. What kind of fluid?
Hydro.
Urine.
Urine back up in the kidney.
Come on, birthday girl. It is urine that is getting backed up into the kidney. Because the kidney, that's where urine is formed, and it has to make its way out. But if there's some kind of obstruction, the urine gets backed up and causes hydronephrosis. And so if the tube is dilated as well, are you having trouble finding where it is? Because I made it up. No.
That's pretty much how we've been feeling.
It's possible. It says check for hydronephrosis, and then you'll put color Doppler on there. I'm just summarizing it like 20 lines. No, I didn't. Because it put me to sleep the other day.
Which one?
My face asleep the first day.
And I pay attention. Exactly.
And then I'll check it.
Yeah, I was really enjoying it. Monday.
Yeah, that's exactly. This is my second time doing that.
Yes.
We'll get my hands together.
I like this.
I thought it would help.
I know.
So y'all might even want to do it now.
Number 8 is ovarian abscess.
Alright, where are we?
Okay.
Ovarian.
So, if you think that there's a dilated ureter, check the kidneys for hydronephrosis. Check both of them. And then you can check the bladder too, because if the ureter is dilated, you can follow it and try and follow it into the posterior portion of the bladder. You guys know where that is, right? You know where the ureters come in. You see whenever you are scanning, them going up with their teeth. The ureter. They go this way, crisscross.
Omega has power. We had the video.
Y'all videoed her.
But it's like fireworks. Miss Abel said she's never seen you like
You got fireworks.
You don't fill up with titty and you're crying. That's fine, I don't know.
I bet y'all two have known each other for a long time.
Well, I don't know, 8 or 9 years. We met in class, in the program.
Memory lane. That's where you look like you went.
Oh, well, it was, because I just, it's really the first time I had really got to know who she was. She was like in this cat fight out in the hallway. We're like, who was that little blonde girl? And she's like, well, she got the big blonde hair, but then there was this like woman that was up to here and was like, just a big woman, and she was out there like, they were going out. We were all like, what? And they were like the junior class too, and we were the seniors. Yeah. Okay. All right. Alright, so check for hydronephrosis, check the bladder, make sure there's no masses in there causing the ureters to back up, and you can follow the ureters, make sure there's not a kidney stone or a nephrolithiasis that has lodged, got into the ureters, has become a urolithiasis, and has blocked the ureter that way. So you can check that. And then if it's a vessel, if it may be a vessel, that's easy. Just throw color on there. If it's not lighting up, try power Doppler. And if it's not lighting up, then you know it's not a vessel. Alright, sonographic findings of PID. So it's in addition to hydrosalpinx or pyosalpinx, sonographic findings include fluid in the cul-de-sac, mild uterine enlargement. What is a uterus supposed to measure? Normally, just in your average monarchical person.
That's the vagina.
I'm not yet.
That's 9 inches. Go on, birthday girl, give me a guess.
15.
Oh, God.
I thought it was, yeah,
I thought it was more like 9 to 12.
12 or something.
6 to 8.
6 days.
Of course.
It can vary, though. Some people got long uteruses. Two of y'all in this class got some long uteruses. So there's some variation in it. But just textbook, according to the book, that's what it says, 6 to 8. And then you got little bitty uteruses, because they don't have babies. Alright, and then endometrial fluid or thickening. So the endometrium may appear thickened, and then you may even see some fluid in there. How do you measure an endometrium when there's fluid in it?
Here.
And then you add
I
a
leave
little
the
there.
fluid.
Good job. Okay. So skip the next sentence. Pelvic fluid may frequently have internal echoes, septations, and fluid levels, a sign that the fluid is not simple, but rather it may be infected or hemorrhagic. So again, just repeating ourselves, if we see the internal echoes in the pelvic fluid, can be due to infection or hemorrhage. Okay, so here is fluid. Where is this fluid? I don't say pelvis, I know it's in the pelvis. Specifically.
Anterior cul-de-sac.
Good job.
Birthday girl.
Congratulations, birthday girl. You got one right. All right.
Gosh, so mean.
All right. So here's the vagina, and then here's the uterus. Here's fluid right here. Where is this fluid?
Posterior cul-de-sac.
Girl, she's on fire.
I was right. Rectal uterine pouch. This is pretty fluid in posterior cul-de-sac. All right. Good job. What?
What is it called, man?
What?
What is it? Pouch of Douglas?
Pouch of Douglas.
When I see people's names in the words, I get scared of the small ones.
Oh. Morrison's pouch.
Yeah.
That's the under the liver.
McBurney's point. What?
Isn't that one under the liver?
Mm-hmm. All right. Tubo-ovarian abscess. You ain't got very far.
No, we haven't.
What's wrong with y'all? It's only like 30 minutes. You got 2 babies. All right.
This is gonna be short. It's only
Tubo-ovarian abscess. Adhesive edematous and inflamed serosa may further adhere to the ovary and or other peritoneal surfaces, which distort the anatomy. As the infection worsens, peri-ovarian adhesions may form. The ovary cannot be separated from the inflamed dilated tube and is called the tubo-ovarian complex. So the tubo-ovarian complex is where the tube and the ovary have kind of fused together due to these adhesions. And you can, if you're not sure if they're kind of fused together, if you see this mass and you don't know if it's all ovary or if it's something else, it's saying that you can do like, the book is saying you can do like gentle pushing with the transvaginal probe to see if one moves this way and one goes that way. If their patient is really like hurting, don't do that, okay? Alright. Periovarian adhesions, again, this is just like what we just got through saying. We're going to repair some block. The periovarian adhesions fuse the inflamed ovary and the tube, and the ovary cannot be separated from the tube. So the tube and ovary they're like one and the same thing. Tube-ovarian complex. And then this causes further loculation of pus, and once that pus sets in, that's infection, can cause an abscess. It's a tubo-ovarian abscess, or a TOA. Okay? Got it, Larry?
No, I was just thinking about something. There's so many pathologies with this that how in the world can you, clinically evaluate it properly? I mean, just.
You remember them eventually. I mean, there's so much done to you right now. I mean, you can't just memorize all of it right now, but eventually you'll see things over and over again, and you'll get it all.
Right? So you can't memorize it all now, but you're fine.
Yeah, I gotta know what you guys do know right now. Because what if you memorize something and you don't memorize something?
That's very likely.
I'll put it all on there, and we'll just see. We'll just see what happens. I know. They read your book.
I've read it. Yeah.
How many more chapters do you do?
I don't know. Should we read your book?
No. So much work.
All right. So with this, what we talked about earlier is how tubo-ovarian abscesses, they do, the infection does respond well to antibiotics. So you may not, the patient may just need antibiotics, not have to actually have any surgical drainage procedure performed. All right, so let's go to page 1032, down to sonographic findings. A pelvic abscess is usually a complex mass in the cul-de-sac that distorts pelvic anatomy. So it's going to be hard to tell uterus from ovary, from fallopian tube, from just general adnexa area, from bowel. It may get hard once you get kind of in the progressive, severe, chronic state of things. But infection can involve the ovary alone, which is the ovaritis, or it can involve the fallopian tube and the ovary together, which would be a tubo-ovarian abscess. The TOA appears as a complex, multiloculated, you guys remember what multiloculated means, right? Alright. Mass with variable septation. So variable septations, there's just no certain sign of that, they'll just be wherever. Irregular margins and scattered internal echoes. Alright, there may be gaps within the abscess as well, and this can cause a comet tail shadowing effect. Have you guys learned that yet? Did you guys learn that last
Today.
year?
That's today.
Oh, today. Are you excited? Okay. Alright, so here is down at the very last paragraph under the sonographic findings, highlight that first line where it says the sonographic appearance may be indistinguishable from other adnexal masses and clinical correlations necessary for the correct diagnosis. So it may appear the same as some other adnexal mass. So that's where the patient's history and the clinical findings, reading their chart, or over looking at, their labs and their, if they've had PIV before, certain things like that, you can kind of go in and help narrow it down to possibly a TOA. Alright, so here this patient has bilateral TOAs. And then also you have to see this like dirty shadowing here from the endometrium. See, the uterus is kind of hard to tell right here because there's a distortion of the pelvic anatomy. But here, this is our uterus, and this is where our endometrium is. There's all the shadowing because there's air in the endometrium here. Here's another tubo-ovarian abscess. And there's another. This is on the left side. And here's another. So they look multiloculated. Septations, they can be, kind of variable. They have internal echoes that are just kind of scattered all over the place. All right, peritonitis. That's the inflammation of the peritoneum, which is the serous membrane lining the abdominal cavity and covering the viscera. What is the part of the peritoneum that covers the abdominal cavity? What part of the peritoneum is that?
The peritoneum.
What part of the peritoneum?
The brain.
Yes.
Woo. Go ahead. I'm scared.
What? Yeah. And what is the part? What's the one that covers the viscera? The visceral peritoneum. What is viscera? Organ. All right. This inflammation is caused by infectious organisms. Okay, let's flip the page. All right, last sentence of that paragraph says, if the infectious process spreads to and involve the bladder, ureter, bowel, and adnexal areas, it becomes pelvic peritonitis. So once if it's not just in the abdomen, it gets down to the pelvis, then it's pelvic peritonitis. And here is some pelvic ascites. And this is due to the peritonitis fluid has accumulated. We can see our uterus getting distorted and pushed anteriorly. Here's our bladder getting pushed anteriorly and laterally to the side there. Here's another one. All these different multiloculated septations here in our uterus. Extremely echogenic. All right, so endometriitis is infection of the endometrium. It can be divided into obstetric and non-obstetric cases, and this is how it started, like what caused it. Was it an obstetric reason or a non-obstetric, which is a gynecologic reason? But non-obstetric infections are associated with either PID or gynecologic instrumentation. So either you had PID and that's what caused it, or if you had some kind of procedure done, they actually had to put like instruments up in there, like if you had a DNC, or if you went to the gynecologist and to get your IUD taken out, and they had to like shoot the little thing up in there to get it out, so maybe the string got pushed to the uterus.
What?
What?
They shoot a thing in there?
They do shoot a thing in there. Yeah, because they got dilate your cervix, and I mean, I was popping noise, and then shoots in there.
Fish it out.
Yeah, fish it out, because there's no the string got more.
Check for your sure. I got it.
Yeah.
Make sure you check for your story.
The IUDs?
Yeah. They had a recall.
Yeah. I
Well,
love
they
it.
always do. I know, I love mine
Yeah.
too. I mean, I had to have it surgically removed the first time, but I still love it. And it's not because it.
Saying, I'm an alcoholic, but I
Look, there's a good apologist.
All right.
Yeah. It didn't perforate my uterus or anything, just the string went away.
Learn a lot.
I know, it evaporated.
Scary.
All right. Acute or chronic obstetric cases occur in the immediate postpartum period, and that's the most common cause of a fever in a postpartum patient. So if you get a fever that's 101 or greater after that initial 24 hours, and you have it for 2 days consistently after that, then that's called a postpartum fever. All right, last sentence of that portion, clinical presentation includes fever, uterine and adnexal tenderness, and bleeding. All right, sonographic findings. The endometrium may appear thick, can contain fluid, air, or clot, or it can even appear normal. Can't make it easy on you. The endometrium is considered normal in size up to 20 millimeters. Now this is going to be like, I'm assuming they're using 20 because it's postpartum, because we know that 14 millimeters and less is what is normal. It needs to be 14 or less. Endometriitis, hemorrhage, or retained products of conception can be reasons for why the endometrium can be measuring greater than 14 or even 20 millimeters. And the risk for endometriosis goes up whenever there has been a premature rupture of membranes, and that's where the amniotic sac of the baby's in, like your water breaks early, that's what that means. And then retained clot or product of conception, and then also prolonged labor. So if you're pushing for a long time, having a prolonged labor, you can get endometriosis, and then you can have a fever after postpartum. All right, endometriosis and endometrioma. All right, let me show you some endometriosis pictures. So here's a thickened endometrium. Here's some fluid in our endometrium. There's some air in our endometrium. All right, endometriosis is one of the most common gynecologic diseases. It is defined as the presence of functioning endometrial tissue in abnormal locations. I know we've talked about endometriosis and endometrioma for like the last 3 or 4 weeks, but we're going to do it again. The ectopic tissue can be found almost anywhere in the body, especially in the dependent portions of the pelvis or cul-de-sac. Clinical findings include severe dysmenorrhea, which is a painful period, chronic pelvic pain from peritoneal adhesions and bleeding, and dyspareunia, which is painful intercourse. All right, next page. Second paragraph. Endometriosis has 2 forms, internal and external. The internal endometriosis occurs within the uterus, and that's adenomyosis. That's what we talked about then. It tends to occur in older like older women that have had a history of like uterine surgeries, like C-sections and maybe like DNCs or having fibroids removed. And then external endometriosis is outside the uterus. The more common form is the external form. The endometrial tissue is in endometriosis cyclically bleeds and proliferates as stimulated by changes in hormonal influences. So the ectopic endometrial tissue is still functional. Down the next paragraph, the second less common form is adenomyosis.
It's the 4th paragraph. Well, the 3rd that started on the page.
The second less common form of endometriosis is the internal form, and that's adenomyosis. Endometrial cells begin to grow into the uterine body, invading the junctional zone and the myometrium. So you no longer have that border between endometrium and myometrium. The endometrial tissue is invading the myometrium. And you can see, let's see, clinical symptoms are, heavy menstrual bleeding, painful menses, and uterine enlargement. Adenomyosis is most common in women who have had the surgeries we talked about. Sonographically, the uterus may appear bulbous. I think we had talked about it being like kind of a globe shape last time. But it is like rounded. There may be myometrial cysts. These aren't like true cysts. And the border between the endometrium and myometrium becomes indistinct. Can't really tell. There's a blurred border. And it's typically on the posterior aspect of the uterus. Alright, so here, this is one picture that I know I showed you guys when we talked about adenomyosis the first time. So there posteriorly. And then here's that globular uterus that we saw. You have the endometrium kind of like invading the myometrium. Endometriosis can be either diffuse or localized. The diffuse form is the most common, and it's rarely diagnosed by ultrasound because the ectopic implants are so small. And this can cause disorganization of the pelvic anatomy and can give it an appearance similar to PID. The localized form consists of a discrete mass called an endometrioma or a chocolate cyst. Endometriomas are usually asymptomatic and can frequently be multiple and have a unique sonographic appearance. However, if they are on the ovary and they become large, it can cause the ovary to twist on itself and to tors. And then, we don't really know what's the cause of it. It could be due to, menstrual flow going backwards, or to, at a cellular level, the cells have become endometrial cells, kind of like ovarian cells, or whatever they're supposed to become. All right, next column, where it says endometriosis may occur in any menstruating female. Clinical symptoms, again, are painful periods, painful intercourse. You can have lower abdominal, pelvic, and even back pain. It can radiate back there. Irregular bleeding and infertility can occur, secondary to the adhesions and fibrosis. All right, under sonographic findings, diffuse endometriosis is rarely detected sonographically, unless there is a focal mass, which is an endometrioma, is present, then we can see that. Endometriomas may appear as bilateral or unilateral. Ovarian masses with patterns ranging from anechoic, which is rare, so they can be completely cystic appearing, to solid, so where they have such echogenic, such low-level echoes in there that it may even appear echogenic or solid. This depends on the amount of blood and the state of its organization, so how fresh and how old it is. The ovaries typically adhere to the posterior surface of the uterus or are stuck in the cul-de-sac and may be difficult to define. Again, this isn't always. Posterior is one of your answers on your sheet, just so you know if you haven't done yet. Next paragraph. An endometrioma often appears as a well-defined, predominantly cystic mass. Again, it's called that chocolate cyst because it has low-level echoes. Endometriomas can vary from cystic to solid, and their size varies widely from less than 1 centimeter to more than 10 centimeters in diameter. So they can be very small to pretty big. Alright, so here's an endometrioma. Those low-level echoes. Here's another endometrioma. So interventional ultrasound. Ultrasound-guided percutaneous biopsy and abscess drainage have become valuable diagnostic and therapeutic procedures. Thinking this may become more of a thing, even more so once Medicare and Medicaid change. One thing that, a patient's bleeding history can be evaluated with platelet counts, because you don't want to do any of this stuff if someone is going to bleed a lot. If they're on blood thinners like aspirin, Coumadin, heparin, Plavix, Xarelto, these all thin the blood. So you can get tests done, which are the INR, the PT, and the PTT. These can get checked, and you'll always want to tell the doctor this is what the INR is. We always look on the INR, and depending on what it was, we would do it or not. And if it was too high, the INR was too high, then the doctor would say, no, let's just wait. Or they would say, we really need to do this. The benefit outweighs the risk. Let's do it. All right. And so here, I just wanted to show you guys, so this may be what you see. Whenever you do a paracentesis, see on this bowel here, you can see that needle, as it punctures, it goes into the bowel and it gets into the fluid there. And that way you know that it's not puncturing any of the bowel, but it is all the way through the wall, so we are going to get some fluid out. And this is just kind of cool because this is a vessel here. But this is like a wire going in, really. That's what I use in the vein system.
What?
This is, I just want to show you, I know this is back, so I just wanted to show you what it looks like. This is ultrasound guided, like percutaneous type stuff. This is actually going through the skin and getting into there. So it's like we had a needle, we'd get into the vein, and then we would thread a wire through there. So this is actually a wire, because there's not no needle being in like that.
What's the purpose?
I just wanted to show you what's
No,
going
what's
on.
the purpose of the
Oh, it depends. So this is venous access. We did this in the vein center whenever someone had venous disease. They had venous reflux. This was to go shut that vein down and burn it up.
burn it up.
Nadia? Yeah, and then post-operative, you always, this can be used to check whenever someone's had surgery, and it's just to check to see if there's any kind of complications from it, like hematomas or abscess formation. So you'll just kind of check around wherever it's tender in the patient heart just to make sure there's no abnormal fluid collection. Okay.
How was that at UTC?